So I'm very excited to announce our closing speaker. She's a true advocate for our profession and the first certified dental therapist in the country, CHRISTY Fogarty.
All right, I'm a clinician, not an IT person. Look at that. Got it going. All right. So, thank you to the Minnesota Dental Therapy Association for having me here today. I would say thank you for the invite, but I'm going to be honest. As soon as I heard we were going to have our first ever convention, I said, let me talk, let me speak. Because as most of you know, if you put a microphone in my hand, it's very hard to take it away. 10 years is a pretty amazing milestone, but we stand on very, very, very tall shoulders. For those of you who don't know me, I am the example of career laddering. I went to Normandale Community College when they still had a dental assisting program. I started out in dental assisting. I went back to Normandale where Colleen, who has influenced probably everybody in this room in one way, shape, or form, was my second year lead for hygiene and really gave me a passion. And I'll never forget when I said, Colleen, we're about to graduate, and I said, okay, we get 2 hours to see a patient. When I start in practice, they're giving me an hour. What do I cut out to make sure I get this done in an hour? And she said, you don't cut out anything. You do it all. You'll just get faster at it. And I've lived by those words and that philosophy my entire career, so it was incredibly insightful. So that's a little bit about me. This is at that first graduating class. This is the picture most of us prefer, Colleen, so thank you. There's one that's really awful. I think the 7 of us, 6 of us hate the picture, and it's been used all over the country. So this is a preferred one, even though I have kind of a weird look on my face. And I do want to take a minute to thank Kelly Meyer. She has dental therapy license number 1. I have dental therapy license number 2, only because she went to the Board of Dentistry after they issued us dental therapy licenses number 6 and 7. And she said, no, that's not happening. So thank you for that, Kelly. I've never known if I've ever. So I'm going to talk about where it all began, right? New Zealand. We've talked a lot about this today. And some of this is going to be kind of repetitive because our foundations are what they are. And New Zealand was very forward thinking. They just celebrated 100 years of dental therapy in New Zealand last year. So it's pretty amazing. So when we look at 10 years plus 1, they're looking at 100 plus 1. So we stand on very tall shoulders. It all began, actually it began more than 100 years ago. This is where I have to cheat on some of my notes here. We have to go all the way back to 1905, and it was the very first meeting of the New Zealand Dental Association, and Dr. F.W. Thompson had done some research, and he presented a paper called The Teeth of Our Children, and he had claimed that 98% of the children at Christchurch Elementary had not received needed dental care. The majority of the children had teeth that were beyond saving. And after that conference, a lot of the dentists agreed, we need to do something. And they began to lobby the country, the state, to come up with some type of a children's dental plan that was nationwide to help our children. And at the time, it was very much an attitude of national efficacy and fitness. The country really saw children as their future and their social capital, so they really did want to invest in them. But then World War I hit, and what Dr. Thompson had said unfortunately came true very quickly. Many of the young men that were recruited to fight were actually deemed unfit for service because their dentistry was so bad. They literally could not get them out. So the New Zealand Dental Association came together very quickly, and they created the dental corps, and they got these service members ready for service. So as the war ended, the state was very, very grateful to the New Zealand Dental Association and the dental corps for all the work that they had done. So they agreed to create the School of Dental Services. Sorry, I keep talking and I'm not really moving forward. So this is the school in New Zealand where it all began. The school was founded in 1921, and the first class of dental nurses, as they were referred to then, began training in Wellington. And they called them dental nurses because it was supposed to kind of reflect that doctor-nurse relationship with dentistry and dental nurses. They studied for 2 years, and they would treat children up to the age of 13. And with less education, they took less time and less money to train. Boy, that sounds real familiar, doesn't it? Initially, due to the very poor oral health of the children, dental nurses were extracting hundreds of teeth. A dental nurse from Dundee had commented that in the early experiences, she was one of the very first in that first picture that you saw. She extracted 1,700 teeth the first year in service. When they first started providing care, the state-funded schools would only treat children, and they would treat them from youngest to oldest. This created a couple problems. One, parents didn't understand why some kids were coming home and had their dental treatment done and others weren't. And there were also many children in the school whose parents were paying into this fund, but they didn't have that opportunity to access care at all. And that was partly because upon graduation, schools would be given a dental nurse, and they would be given an area and very fancy equipment to set up a dental clinic, but the school itself had to maintain it, order the supplies. So some schools were more generous than others, and it created a lot of inequity. At the time, they only took single unmarried women because women were seen as temperamentally and psychologically more deemed to treat young children. And in the late 1930s and 40s, the SDS continued to see improvements. They started out with this is how they kind of gauged how they were doing. You can see in that first year when that 1,700 teeth came out by that one therapist, for every 100 fillings, they were taking out 114 teeth. And by the early 50s, they were seeing a filling ratio actually all the way down to 6.3. So they made great improvements with that age group. So ages 13 and under, they were getting regular care. They continued to expand it, so all the children were being seen. But soon it was apparent that the policies were just shifting the problems further, right? They started to see problems then at 14 and 15, 16 and 17. They continue to see that just keep going up and up and up. Sorry, I got a little lost here. While the SDS main focus was still full coverage efforts, efforts were made to providing oral health instructions, cleaning teeth, and they applied silver nitrate. My question earlier, they began using that all the way back then to arrest early carious lesions that had been part of the role of dental nurses. The introduction of fluoride to the SDS was perhaps the most beneficial, and in 1950, they began applying fluoride to children's teeth. Over the next couple of decades, the profession grew along with the baby boom population, and married women were now allowed to work. 2 new training schools were built in 1915, one in Auckland and one in Christchurch, and the student intake reached a peak in 1964 with over 270 students being enrolled. All right. Sorry, guys, I'm a little lost here. All right, by the end of the decade, there were 1,300 dental nurses in the field, and by March of 1970, the number of children under the care of dentists had been reduced from 16,000 down to 10,000. It was anticipated that the patient group would soon include, for the first time, every single child in the country, and including many of the preschoolers, and the extraction to fill rate had dropped to 2.8 extractions. Sadly, like many other countries worldwide, the 1980s brought recession, high unemployment, and inflation, and the government began to cut SDS services. Downsizing the SDS meant fewer dental nurses, reduced salaries. There was also over 400 dental nurses out of work, so a significant surplus existed. One of the changes in that time was they changed from dental nurses to dental therapists. After significant reforms in the 80s and the 90s, the early 2000s saw a significantly push for better health equity, as many of us have seen throughout the world. They moved the SDS to the Community Oral Health Service, and in 2000 found that free dental care during the school year reduced the effects of inequity that dropped off after the age of 26. New Zealand took a new approach, and today New Zealand has about 1,200 oral health therapists serving throughout the country. So you can see this is their new approach. They kind of dropped the School of Dental Services and they become community oral health care services. And they really emphasize prevention, early intervention, and continue today working in schools. So that's kind of the basis of New Zealand. It still tends to be very, very strong profession. Many of them are dual licensed now, which is true in most of the other countries. Moving on to the United Kingdom. Actually, starting in World War I, the UK had what were known as dental dressers. They did many of the things dental therapists do today, but dentists did not like the profession. So after World War I, in 1923, they had dental dressers abolished. And the School of Dental Services was largely neglected during the war, and at the start of the National Health Service in 1948 caused many of dentists to move to private practice to make more money. So with the future of the SDS in question, the UK looked to New Zealand for inspiration. In 1951, UK government officials went down to New Zealand to look at their dental nurses. And they reported that the nurses provided a high standard of treatment. There was a significant degree of controversy and opposition from the dentists to the idea of introducing this type of practitioner to the UK. However, the Dentist Bill of 1957 allowed for the General Dentist Council formation, and their goal was to begin educating what they called dental auxiliaries. 1959, the first class of dental auxiliaries started at the New Cross Hospital in New London. They were chosen from across the UA, and after graduation, they could be assigned anywhere in the country. And they had to actually sign an agreement saying that they would do that, but it was really difficult to enforce and sometimes tough to get them to stay where they were assigned. They were first only allowed to do simple fillings and extractions of primary teeth. Over time, that grew. The 2-year program was paid with grants from the Ministry of Health, and it cost about €240 for the first year and about 250 for the second. And 60 women were in each program. They often slept 5 women to a dormitory. Those offered a place at New Cross were placed. Oh, sorry, I already said that part. Here we go. For 20 years, dental therapists were trained at New Cross. However, in the late 1970s, a government review concluded there were enough dentists to treat the population. So an organization called the Nuffield Foundation, it's a lot like our Pew Charitable Trust, they did an inquiry and they looked in and they found the exact opposite. They said that actually we should expand dental therapy and we should expand their scope of practice. There is a huge lack. Unfortunately, despite that recommendation and the success of dental therapists, a 1981 report on dental strategy recommended the closure of New Cross, and this was largely seen to attempt to abolish dental therapists. They were unsuccessful in abolishing dental therapists, but it encouraged many people to seek dual licensure, so many of the New Cross graduates went back to dental hygiene school, and they integrated the education and they adopted it in 1980. Many of the New Cross graduates still are working today. They work as dual licensed therapists and hygienists. Oops. In 1960, and I actually, when I was in Ireland speaking on this topic last month, and if you guys, I seem all over the place, it's because this is a 3-hour presentation I'm trying to do in a half hour, so I apologize. She came up to me and she said I was actually one of those New Cross graduates, and many of the New Cross graduates are trained. They live in actually Ireland and they cannot do dental therapy at all. So we'll move on to Canada. I always call this a cautionary tale because it's been a little bit tougher in Canada. In the 1960s, dental health inequities were being experienced primarily in the Canadian Inuit and First Nations people. They had increased rates of decay, particularly in children as compared to the general population. For example, the Inuit people had the highest rate of oral decay surgery, 97 per 1,000, so dang near 10% of the children had to have surgery. And that was in a comparison of 0.8% of the general population. The government realized a lack of dental coverage by universal health care, in addition to the lack of dental providers, were the main drivers of these inequities. It was recommended to create dental therapists, and this would expand the number of dental providers. In 1972, 2 training centers were opened. One was in Saskatchewan at the Regina General Hospital, and the other one was in the Northwest Territories at the National School of Dental Therapy. Dental therapists were trained to work in rural and remote areas. In 1972, the Children's Oral Health Plan was introduced. Free oral health care in school-based clinics in the tribes were created. Oral health care greatly expanded for children. But dentists continued to argue that they should be doing this care and that dental therapists should be working under their supervision. DDS argued that these services, their efforts allowed for the passage of Dental Professionals Act in 1978, and what that did is it allowed dental therapists to work in private practice in Saskatchewan. So now dental therapists had urban options. I always call it kind of the beginning of the end. Then it became significantly more difficult for the government to recruit dental therapists to the tribal areas. At the same time, dentists became more and more vocal of the opposition to public-run programs. In addition, at the same time, nothing to do with dentistry, but 15 government officials were convicted of fraud, and it just made people really leery of government programs. The result was the elimination of the Children's Oral Health Plan, and the clinics were removed from all the schools. And this is just to kind of give you an idea about how Canada is laid out. Saskatchewan and Regina's were one of the training centers once. The other one was up in the Northwest Territories. The vast majority of the indigenous people live in those areas, so it really gave them a lot of access. So pulling all the clinics out of those areas and pulling the training centers out was very, very destructive to dental therapy in Canada. With most DTs in urban cores and private practice, the perceived need for dental therapists also continued to plummet. Between 2003 and 2007, there were only 73 graduates from dental therapy programs, and sadly in November of 2011, the last dental therapy program closed in Canada. The remaining dental therapists in the province of Saskatchewan are self-regulated and are required to register and be licensed with the Saskatchewan Dental Therapy Association. So when I was in Ireland again, I was approached after I talked, and someone came up to me and they said, dental therapy is coming back to Canada. As of right now, they are planning to open a new program starting in March of 2023. They're going to take applicants, and in the fall, they're going to start a new dental therapy program. Again, it is in the Saskatchewan area. They seem to be the ones that are most interested in continuing with dental therapy and pushing dental therapy forward. Currently, right now, in Ontario and Quebec, where 22 million of the 37 million people who live in Canada are, you cannot practice dental therapy at all. And it's also important to note that the 100 miles closest to the border is where the vast majority of the population lives, so it's very difficult for them to receive care in the northern part of the country. All right, moving on to the U.S. At the same time, the Surgeon General report that Colleen had talked about and the call to action that asked for more providers, Alaska was looking at, their tribal leaders were looking at the abysmal oral health conditions and the lack of dental care in their communities. They came together to create a different health future for their people. And the Alaska Native Tribal Health Consortium, or ANTHAC, it's a nonprofit work group, sought to find solutions for oral care providers. Alaskan Natives have been challenging in getting equitable care because many of the state's 200 villages are only accessible by airplane or by boat. Tribal communities had to transport people from the regional hubs for basic procedures, including incurring high cost Medicaid and the tribal healthcare system. Surgery costs a minimum of $7,000 per child. Bethel, Alaska serves 26,000 Alaskan Natives from 52 villages, but there's 200 villages in the state. Again, leaders looked to New Zealand, and the dental health aid therapists were introduced as a solution. Prior to DHATs, often villages would have to wait over a year for even one visit from a dentist to their village. With this proposed, the American Dental Association, as we talked about before, they actually had a $150,000 advertising campaign against this. They fought it. The ADA actually filed a lawsuit in an attempt to stop dental therapists from practicing in the indigenous tribal lands in Alaska. They lost that because of tribal sovereignty. ANTHAC sent students selected by their tribal communities to the University of Otago in New Zealand. As Carrie talked about, the first 10 dental therapists were trained. That's the very first class of dental therapists that actually went to New Zealand to train. Dr. Mary Willard was the one who brought dental therapy training to Alaska. She started the Alaskan Dental Therapy Educational Program. It's a 2-year, 3 academic year program, free for all students. Their tuition, supplies, living expenses, travel expenses are paid for by their sponsoring tribal organization. It's about $140,000 for the 2 years. The students pay back their education by serving their tribal lands for 4 years. They take between 6 to 10 new students each calendar year, and during the first year they train on models by learning how to perform simple preventative procedures like fluoride and sealants, and then work up to more complex procedures like fillings and extractions. And it was the first program to receive CODA accreditation. Continuing legislation in several states oh, sorry. This is how that state is laid out and how they are most. It cuts off. Alaska comes all down through here, but Anchorage is here. They train there. Bethel's where they see about 52 of the villages come and train there. The rest of the therapists are spread throughout the state. Meanwhile, in the lower 48, access to care issues continued to grow, and dentistry looked to dental hygiene. The first thing they did is they allowed us to continue to have direct access. You can see over the years they continued to have direct access for dental hygienists, to the point where we have almost every state has direct access for dental hygiene. It's fantastic for getting preventative services. They also started to expand our scope of practice, more and more things that we can do. Things like restorative functions was added to many states, but it just wasn't enough. So then we go to Colleen Brickle, and I won't go on, but as she's been an inspiration to so many of us, and it was a huge train that got dental therapy to Minnesota, but Colleen for sure was the engine that drove that train. So we will forever be in her debt. If there is an Esther Wilkins in dental therapy, it is Colleen Brickle. So Minnesota took that first leap into legislation in the United States. This is where dental therapy practices. This is from a 2015 group. Most of us are in private practice now, which I think most people did not think was going to happen. I think they thought we would stick with the FQHCs. I didn't think they imagined that dental therapists would get into private practices and continue to see that underserved population, but we have done it, and we have done it in such an impactful way. I think it's very, very difficult for us to continue to understand exactly how we work, and much to where did Prashita go? Much to what she said, it's very difficult to see where we work, right? Because I myself would be counted as a Twin Cities dental therapist who spends very little time in the cities. I spend at least half of my time in Southwest Minnesota working in mobile clinics. I go everywhere from Moorhead to Worthington to Stillwater to the Iron Range. So I am very rarely there, but I'm counted as one of those, and I am not alone. And I think we've seen this all enough today, right? We are going to continue to go. Every day I continue to say all 50 before I die, and someone said, you're going to die in Hawaii, and I said, I'm okay with that. So I know that was fast and dirty, but I'm always told you never want to be the speaker before lunch, and you never want to be the speaker before cocktail hour.